The next disease is Kawasaki disease, formerly known as mucocutaneous lymph node syndrome. It was originally described in Japan by Dr. Tomoyasu Kawasaki and now has been described all over the world. It's an acute vasculitis of all the vessels, particularly the coronaries, and if there's anything, a take-home message for Kawasaki is remember coronary artery disease, particularly coronary artery aneurysms. It's found worldwide. The highest incidence is found in Asians. It's the leading cause of acquired heart disease in both the U.S. and in Japan. The majority of patients are less than 5 years of age. Once again, read the question, look at the patient's age. It has been described in older children. We are seeing more cases of what they call atypical Kawasaki, but for exam purposes, look for someone who's less than 5 years of age. This is also a diagnosis by exclusion, and you have to have a certain criteria. First criteria is fever. The fever has to last 5 days or more, and then you have to have 4 of the following 5 criteria. So again, a test question would describe this to a T. You would say, they would tell you about the fever, and then they would start listing other criteria, and you just keep clicking them off, and then they would ask you what else you're going to do for this patient. So look for bilateral, non-purulent conjunctival injection. So they do have a conjunctivitis, bilaterally non-purulent. They can also have mucous membrane changes. These include an injected pharynx, the strawberry tongue, dry, cracked lips. You're going to see some pictures shortly. Third is the peripheral extremity changes. This is the peeling of the fingers and the toes from the nails back, like in a glove and stocking distribution. They can also have edema or erythema. They have a rash, and they can also have cervical lymphadenopathies. Even though it used to be called mucocutaneous lymph node syndrome, the cervical lymphadenopathy is the least constant feature, and it has to be a lymph node that is greater than 1.5 centimeters in size. That's a cervical lymph node. Here you see a patient with the characteristic rash of Kawasaki's. They can also have an indurated type rash or indurated edema. And here are very red lips, and this is what they call the strawberry tongue. Sometimes with strep pharyngitis, they describe a white strawberry tongue. In Kawasaki's, it's a very brilliant red tongue at times. This is the skin desquamation. You can see that the fingers are starting to peel back down this way, and here's another one. And they can peel all the way back down, basically to your wrists, and the toes, it happens all the way to your ankles. Now, there are other diseases that can cause some peeling, but you got to put all these criteria together and you reach your diagnosis of Kawasaki. Patients are sometimes very irritable. They feel sick and they act sick. They don't want to be messed with. They can have an aseptic meningitis. They can have diarrhea. Remember, high drops of the gallbladder, and it can cause a little bit of jaundice. And also remember sterile pyuria. So you'll have white blood cells in the UA, but you won't have anything growing in the urine culture. The most important thing, however, is going to be cardiac manifestations of Kawasaki, particularly coronary artery aneurysms. Yes, they can have myocarditis. They can also have tachycardia. Sometimes it's in and of itself. Sometimes it's with the fever. But look for aneurysms, coronary artery aneurysms. So if you suspect that the child has Kawasaki, or you have made the diagnosis of Kawasaki disease based on your criteria, you must get an echocardiogram. That's going to be a question. And your treatment is going to be with immune globulin. So your white count may be normal to increased. The SED rate may be increased. All of these tests are helpful, but none of them are pathognomonic. One thing that is very helpful is the elevated platelet count. They reach platelet counts of up to or over 1 million, usually in the convalescent stage, so usually in a couple of weeks after they've been sick. The echocardiogram is indispensable. These patients will have an echocardiogram done as soon as you suspect that diagnosis, and they can have follow-up echocardiograms to make sure that they don't develop any problems, or if they already have problems, to make sure that they are not getting worse. There's really, if they have had no coronary abnormalities within 2 months of the onset of disease, they're pretty safe. Treatment is going to be Intravenous immune globulin, again remember, if you receive intravenous immune globulin, you have to wait 3 months before you receive a live virus vaccine. In this case, aspirin is also recommended for Kawasaki's disease. And I know you're probably thinking, why are you going to give aspirin to a child when we talk about Rye syndrome? Well, in this case, aspirin is the drug of choice, and even though this is suspected to be viral, we don't know that, and we know it's the drug of choice and it won't cause any problems. So these patients receive high-dose aspirin initially. Once the fever is under control, then they can go down to lower dose, and just because of the platelets are being high. Rarely do they need steroids. Initially, you're not going to give steroids, only for patients that do not respond to initial management. So during the convalescent stage, that's when you go to low-dose aspirin.